Siamo pronti? Primo line, please. Okay, I think we're ready. We need to start off with the first live case from China. Okay, hi.
Hi, Antonio.
Hello, everyone. Giuseppe Tarantini, Antonio Colombo speaking here. So welcome to Jim Gise. We're ready to hear from you the case that you have to do today, to perform today.
Okay. Dear Antonio, Joanne, Fernando, and dear colleagues, friends, so welcome you to join our live demonstration streaming from the second affiliate hospital, Zhejiang University School of Medicine in Hangzhou, China. So first, I would like to introduce my colleagues with me here. So next to me is Dr. Liu. He's
Hi.
interventional cardiologist. Maybe you know him quite well. Okay, Dr. Wang and Dr. Jiang, also my colleagues, and one fellows, and we have an echocardiographer over there, and also anesthesiologist, and several technicians are working with us. So first, I would like to invite Dr. Liu to introduce the case. Please, Dr. Liu.
Okay, thank you, Professor Wang. Good afternoon, everyone. Yeah, today the case. Next one, please.
Next one, please.
Yeah, the patient is a 71 years old gentleman. It's a small gentleman. The BMI is about 17.5, and the STS score is 6.4%. And the patient has history of hypertension, paroxysmal AFib, and renal dysfunction, and a COPD. And the patient had the history of the chest tightness and short of breath for 2 years and a greater for over 2 weeks. Next one, please. And this is the CKG right here. Next one. And the coronary is okay. Next one. And this is the TE. From the TE, you can see right here the severe DMR, and the left ventricular ejection fraction is good, and the left ventricle is a little bit dilated. Yeah, next one, please. And this is, this is the TTE. 动一下啊. Yeah, we can see right here very severe mitral regurgitation, and we can see the A1 prolapse right here, and the A1P1 lift length is long enough, and the mitral valve area is over 4 centimeters square. Next one, please. Yeah, so for this patient, which strategy and we can discuss with the long or short, narrow or wide device. Next one, please. Next one. Next one. Yeah, today we will use the Dragonfly system. I think maybe some of you know it quite well. And Professor Wang leading our interventional cardiologist, working together with the Belgian company, we developed this very good device. Yeah, I think the mechanism is quite similar with the G4 system. Yeah, it can be independent grasping and the left atrium monitoring, pressure monitoring. So, however, there's a spacer right there, and we can very accurately manipulate the system. So it's quite easily for us to spread the technique in China. So last year in 2025, over 4,000 cases of TT or MT in China, and over 2,000 cases, half of them we used the Dragonfly system. And that's all for my presentation, Professor Wang.
Okay. I would like to take a few minutes to introduce the fantastic device system. It named the Dragonfly. So actually, it consists of 5 main parts. You can see that the guiding sheath, steerable sheath, and the delivery, the device delivery catheter. Also, one very unique stabilizer. So this stabilizer has 3 quite unique
knobs.
rolling knobs, articulated rolling knobs to advance, holding the grand sheath, the big sheath, middle sheath, and the CDS independently. So also, yeah, both of the sheaths have 2 handles. So one handle for controlling in the anterior and the posterior, the other one for controlling medial and lateral. So actually the clip is quite unique, has a quite unique design. The clip, the 2 arms, the clip could be released while keeping the, keeping the some degrees from 0 to 45. So, so you can keep the 2 arms staying at some degree of opening. Then you can release the device. So also we can, the spacer is compressible. It's a soft one, not stiff one. So we can make adjustment between the 0 to 45 degree. Just keep the to 2 arms at some kind of degrees. So now we already get the guiding sheath in the left atrium. So now we are trying to can you say that? Oh, do you have any questions? What is your comments on the strategy for the case?
Yes.
One thing that, because this is intended, to target actually earlier operators, it would be great, Professor Wang, if you could explain, the basic algorithm, the basic measurements and the basic variables that you take into consideration for clip selection, including mitral valve area, the length of the anterior, the posterior, what considerations, because I really think that's the core of the case, all right? I mean,
Yes,
seeing
we
the case
can-
implanted is one thing,
Yes, we can
but it
go
would be
back
great
to
if you
the
could give us
video
some.
to show the 3D, maybe.
Yes.
3D and fast view. Go back to the 3D and fast view. Okay. 你叫 moving 动起来，动起来，
好，这里
这里叫它
动一下，
动一下，或者你就是 real time
这也可以。
你能不能修一下你的 ？So we let the echocardiographic doctor to show the real time video of 3D and fast.
Yeah.
Can you see the screen?
Yes.
Real time echocardiography. So now we can see the 3D and fast view. Can you see that? Actually, the case
Yes.
has a focal prolapse, close to the lateral. No.
Yeah.
So, but it's not the common region. It's actually
We
it's a
now we
A1.
just seen
It's
the
a
slides.
A1
We need to
prolapse.
see the live. Yeah.
Could you point out with the
We don't
mouse?
see the live echo.
We are not seeing the live echo.
Can we see the
Oh,
live
you cannot
echo,
see the
not
live
this
echo.
slide?
OK，你把这个 live echo
Oh
放
yeah,
到
we
这个
just see the
这个
slides.
PPT 去了它，
转播过去，
转播过去，
切到那个，切过去，
切转播，这个片 PPT 不要放了，
超声切出去。
切出去，超声切去放大。
OK。
Good.
Can you see the real time echo? Okay. So echo Dr. Lin, could you point out the prolapse site? Prolapse with your using mouse. Can you see that? The mouse
Yes.
is pointing out the prolapse, anterior leaflet prolapse, quite focal, but actually it's not the commission region. It's still the A1 prolapse. Color is on, please. Color. Can you see that? The bloodstream coming from the prolapse side towarding the posterior leaflet. Okay.
So we will select
So,
long and wide.
So what is your strategy? You know, what about the device size strategy? What is your favorite device size? The longer or shorter, the narrow one or wider one?
So actually, my comment for this case, I don't know the other in the panel what you think. When I have this kind of prolapse and the area is not so big, actually I would go with the wide and long and to target the prolapse. Usually, when the area is bigger, I prefer to go with a body clip and then to go with a second clip just to fix the defects. In this case, I'm not sure, I don't know if you have any comments about that. Also, Azim is in the room.
One thing that I noticed, and I want the team to confirm, does the patient actually has a baseline gradient of 3?
Baseline pressure gradient. What is about baseline pressure gradient? I think it's a 2 or 3. 야차.
Yeah, 2.
2.
Yes.
2 millimeter mercury.
你测过吗？
I got one. It's a Zim
Oh, one.
One.
nice
Only
to see.
one.
Only
Only
one.
one. What about the
So
valve
I would
area?
also
4.4.
4.4 valve areas. Valve areas
I'd
4.4.
probably use an XT. But these cases recently, we've actually moved to you doing Pascal, because with Pascal, you can really get in the commissure. If you need to go more commissural, if you get stuck between chords, you can easily get out. I try not to use XTWs when I'm in P1, P3, but just because it sometimes won't slip in the chords. And so you end up pushing away the leaflet a lot and curling the leaflet and struggling with that a bit.
But what do you think, Azim, about the fact that you want to go, you intended to go with one or with 2 clips when you have an area like that? Usually, how do you behave?
I mean, if it's a central wide D2 prolapse, I'm always thinking of 2. Yeah, I'm going to start with 1, but I wouldn't have any issue putting a second one, because I think it's with prolapse, it's not about just decreasing color, it's about treating the lesion.
Yeah.
So you got to stabilize the whole prolapse segment. And if you cut corners, just go for 1 clip, get rid of color, the patients come back a few months later.
So, Professor Wang, what is your choice? What is your strategy that you
Okay, actually,
have
initially we are considering using a short and a wide one, but at last we select the longer and the widest, the longer and the wide one. You know, we think that actually because it is not the commissure lesion, so you know it's a A1 lesion, but especially when we put the device, you know, the alignment need to be from maybe 1230 to 630. So this will need us a little bit longer, maybe easy to grasp the leaflets.
And the leaflet is long enough.
Also, the leaflet is long enough. 你把你的切线尾看一下那个，而且我要把大小图了，有没有余地？
有的。
还有多少？还有多少？然后I'm withdrawing the beta sheets.
差不多。
I was trying to get more into details when
你
about
把
your
它放大，
question.
把那个放大，把那个超声放大，放大。
I think it's hard to
So now we fix the guiding sheets. So now we just advancing the middle sheets. You can see that close to the atrial appendage. We just moving toward the anterior.
Azim, have you used this device in US?
It's not available in the United States.
So I think the strategy here is very important when you have the jet that is not so central. As Giuseppe was addressing, you have to be careful, and Azim was also getting to this because of the commercial course, and you have to be sure that if you want to use or not 2 clips right away, so you have to decide it before, not like a bailout strategy, otherwise you're going to be in trouble. Usually when it's the primary disease, we want to be more perfect as possible, because we're trying to replace the surgery here. We are trying to be surgeons here, not like in the functional MR that you can place 1 clip and it's gone. So usually when you have like such a defect like it's P1 or P3 defect, usually we prefer to go for a small clip first, more commissural, then use the central second. But I understand that some people do the opposite, go first with the central clip. But I kind of disagree with this.
For prolapse, I prefer to go with 2 clips in general because one is important.
I do exactly the same.
Stabilize, and I agree with Azim that Pascal is less, you know,
that's exactly what we do.
More respectful of the anatomy and the function.
Yeah.
This device has a little bit of feature of Pascal and the clip, so it's an hybrid. That's and really you see the maneuvers increases a certain amount of precision. They're all graduated. You can write down exactly what the bend you gave, etc.
No, but the point also to Weinstein in this case is the area is small. This is the point.
It's not very small. It's reasonable.
How many clips you can fit?
Well, I don't know specifically this device. It's not in Brazil. It's not available in Brazil. I think it's coming in July. It's microport or that makes the device, right?
So can you see that? Now we open the 2 arms.
The orientation seems to be good.
No, it's not the, you know, it's the A1 prolapse. So we want the 2 arms a little bit clockwise. 你把这个调好一个 arm， 给他那个 alignment 调，
还没转好。
So from commercial view, you can see the trajectory looks good. From 3D and fast, we check the orientation. So I would like to have your idea about the orientation. What do you think? So from the multiple view, we need to make a judgment about alignment, about when is trajectory is good or not. Second one is about is there any hugging or not. Third one is about the clip orientation.
I think at this point, what I used to do is to go with the color to understand where I'm going with the clip. Because if you're heading to go to finish up with 1 clip, it's important not to leave too much regurgitation. And this position, initial position, is very important. So if you can put the color, please, for us is important.
Okay, color is on, please. Color is on, please.
Please. It seems I would go a little bit more central, but actually
I would go more central.
I don't know, Azim, what you think.
You want to go more central? You don't want to be
a little bit, not too much.
Central, yeah.
And maybe you're going to fix your AP just a little bit.
Yeah,
a little bit more plus.
可能要再打点弯，打点弯嘛，它就不像了。So we just add more media on the middle sheet.
Color
is on, please. What do you think? The alignment, the trajectory, and the hugging. Do you think the patient has hugging? The device has any hugging? We try to eliminate the hugging.
I would dive in the ventricle, open the clip, and then, you know.
So because
we have to make some other fine adjustment, because actually I think you can go down.
怎么样？
位置会不会要再来多一点？对，你在 color 上
往里边推一点点。
color 上 ，ladder 好像还有
差不多。
啊。那我们在 M 松掉一点了。好，松掉一点，
差不多吧。
他们还强调要密一点。
差不多。
So just now I think one panelist emphasized, so don't open when we are diving, don't opening the 2 arm too big.
Yes.
It's maybe easy to catch in the corridors. So now we just leave the 30 degree. Now it's a 30 degree, maybe.
Yes.
30 degree. Then we are diving. We are diving now.
Yes.
Okay.
I think it's not too bad. I don't know if you want to open the clip there to understand if you can go. Yeah.
还可以。
我把它抖起来，不用打得太大。So we don't open the 2 arms to the end. We don't do like that. We just
再大一点。
It's
再
too.
大点，再大
I
点
think it's
拉
too
近
Probably it's too probably it's too lateral.
going to A1P1 and
来，
Well, the target is A1P1, but they drop a little
the
lateral.
target is A1P1, but is it way too lateral? I think. I mean, in my opinion.
差不
I
多，
don't
我
over
觉得
little
差不多，
lateral.
再上来一点。
再上来一点。
So I just
color 看看 color。
lift the
know.
clip
Unless he's
a little
really
bit，
intending to put a second clip,
你不能
it's going to
再
be difficult because the patient, there's no size,
再
no
你长伸去掉
size enough for a second clip.
，color off please，color off。Otherwise I cannot，
可以大一点吧，我觉得。
我不能再高了，不能再高了，再高。
可以大一点点。
Would you go for separate clipping or simultaneous clipping?
Yes, we can do both independently or simultaneously. We can do both. This device is a fantastic device.
The posterior seems to be not too bad. The orientation for the anterior
Watch out,
need to
Kaka.
go probably for a little adjustment.
Maybe we need more counterclockwise.
两边看看。
好的，因为从这边来看是有一点，你看这里还有一点，
Yeah, so we should move a little bit more lateral. You agree?
我关小一点，再下一
往里边
点，
推一点点。
再下一点，
好
或者你移不动。啊，要不要 counterclockwise 来一点
差不多了，已经过去一点了。
？counterclockwise. Maybe we need more counterclockwise.
再看看。
好，
再看看啊。
So just to share my practice here, I would go for posterior clipping first, then I would move anteriorly and to go for the second clip
哦
before closing. Or you can go with both. Here is not too bad.
So
Now
could you
it's very
could you
good.
kindly explain why do you
Now it's good. I think
why
it's
did you
very good
do
now.
why do you do first on for the posterior
行，
clip？
现在还行吗？位置？
我觉得
对，
可以的
方。向还可以，位置我
Orientation，
位置再看看。
What do you think the orientation? Please comment on the orientation. Do you think maybe too much
The orientation
counterclockwise?
is not too bad, I think. It's good, I think.
Yeah.
You might say a few degrees
我感觉可能还
counterclockwise.
不够 L，
对，
整个系
Very
统还是。
slightly.
我觉得还
4
在。
5 degrees.
So
counter.
I think we need to
Pretty close.
go forward, go more lateral.
Forward. Yeah.
往
go
前再推
forward.
吗？推不一定推得过去。
要不要下去？
翻转
或者翻转一下？
翻转，我觉得要翻转。再去
对
看，
翻转，
翻转，我觉得翻转因为夹在那个键手上。
对，免得
We want to reverse our we want to reverse two arms.
Yeah, then
we move. 往
yeah,
上面
I already pushed the system.
但是你看从这里看好像还没有移过去。嗯，
换个没空。
Yeah, I think.
要不要松掉点 M？
Yeah, less M.
Less M，
Okay. Good.
张力会不会太大？
再回来。
回来是不是有问题？看看啊，好像一个键手后沿。
Okay, much better.
Much better.
过
Either
去了吗？
little upper, and then I think you can
过来了，
close.
应该过来一点了。
嗯，
Yes.
You make a first try.
Yeah.
你能把后沿看清楚吗 ？Posterior leaflet。
好的，后沿应该是。
那个anterior leaflet。
anterior 在哪？
现在应该在了，都在。
anterior 在哪？
Both leaflets are on. So I think the orientation is good.
Pull up a little more and go grippers down.
So what is your idea? Simultaneously.
My idea is to open a little bit more the clip, a little bit more, just to see, the amount of tissue that you have in. But it seems not too bad. I don't know, Azima, what do you think?
Looks good. Just pull up a little more so you get as more leaflet in.
Yeah, it's here. The anterior leaflet seems to be good.
Yeah, and the posterior is right up to the annulus.
再深一点。
Pull up a little
Pull up a little more
加大一点点，要不要？
拉起来。
and grippers down. A little more. Pull up. Don't be shy.
And then you close
位
it.
置还可以吗？
Okay, I think now it's good.
Pull
You
back.
can close.
是可以，
那我就可以下了，
可以，我就下了。
等一下，多一下。
或者再往后打一个也可以。
你不能再往上去了，你太往上就把这个瓣膜给弄出来了，你不能再往上了。
可以。OK。
那我就下了啊。
Yes.
I want to do simultaneously. Going down.
Yes.
Oh, the posterior is not may not
down.
good. Posterior 没啊。
对，拉起来，重新拉起来。
posterior。
I
Yes.
think you can close the clip.
Yeah. 再下一遍。
Close it.
没感觉。
I don't think the posterior is on.
I can't see a posterior grippers
I
so
don't
well.
think so. I don't think so.
Yes.
哦，回到3位。
你不能太高，你太高就posterior 出来了。
我有 module view。
我再往后打一个。好，再拉起来。OK。
不能拉了，绝对不能拉，再拉就拉出来了后叶。当。哦，不好意思。
后叶不在。
或者我 3D 看一下。
对
，multi
view。multi view please。
multi view please。We are concerned about the posterior leaflet may not be on the arm， 哎，还是不够 lateral， 差不多。位置还可以的，orientation 也是可以的，应该夹住的。我看在台上，但为什么
可能错层了？
有可能错层，
也有可能错层，
因为我们斜过来，
我觉得可以拉高一点，没事。好。
拉高一点就
好，再两个。
你觉得可以往后一点，就不要拉高了。你再拉高就没有了。
后其实我已经打了蛮后了，
再拉高就
好，可以差不多。
You think you should open your arms like Dr. Tarantini said, just a little
bit?
Yeah,
both arms are on. 肯定在。
Okay.
看了看看，在这个地方吗？你觉得？两边看看怎么样？
稍微 lateral 多一点。lateral 还不太够，有点 compression。
lateral 会有一点点。
什么？
lateral 可能后束还有一点点。
还行吧，我觉得。
你拉起来的时候，它会 disappear maybe。
Yeah, I think both leaflets are on. You can close a little bit and see.
你看从那个 3D and fast， we cannot 就是基本上是。
Yeah, close.
Release the tension a little bit, not much.
Okay, good. 再看看。
好。
没有了，突锤没有了。
Yeah, much better. Close more. 再看了。
还有一点。
I don't know why.
有可能还有一点。
It's better.
Okay. Check.
No problem.
再看看。
好。
Okay, it seems very, very reassuring, the grasping.
Almost gone.
Yeah, it's good.
And also the regurgitation.
Beautiful result.
Is good.
Yes.
Now we tighten more.
去掉。
tighten more.
I think when you look at this clip, it's very difficult to think another one.
Oh, we can leave.
Yeah, it's good.
Maybe optimize a little posterior.
Yeah.
Color is on.
Oh.
Color is on, please. On the 3D and fast view. 这个好像没有看到凸槌啊，这边看不见。
Yeah. So are
can
there
we know the
any
gradients?
residual?
Because the regurgitation is almost zero.
Yes.
Is it possible to know the gradients? We have 3 minutes left.
Any change in the left leg?
Let's check the gradient.
Are you satisfied with the position, orientation?
Check the gradient.
Gradient is important because the area is very small.
Gradient maybe 3 to 4.
The deceleration time is good, so actually this should be 3, 4 maximum.
Maybe 5, I don't know. Less than 5 should be.
Maybe 5, but I'm
3 to 4.
You know,
one thing that is we always check is the pulmonary vein flow to be sure that it's working for the patient.
多买几个 average.
Yeah.
Because eventually, at the end of the day, what's going to make the patient feel better or not is the flow in the pulmonary vein. If it has changed from the positive.
We can check the pulmonary vein flow. Check the pulmonary vein flow.
好，等一下，我把这个先撤掉。
the heart rate is more than 70. You can get lower the heart rate.
来，你看看那个肺静脉逆流。
好。
4. Gradient 4.
But I think it's important to understand the gradients in the setting of the LA pressure and the pulmonary venous flow, because a change in gradient might really be something that we kind of may overlook if the LA pressure is going down and the pulmonary venous flow.
And if it's primary disease,
I think you need to interrogate the valve a little bit more, because this last picture you show, there's still a very eccentric jet that's going sideways up the atrium. And I'm a little worried maybe you missing all the prolapse, because I don't like seeing eccentric jets when I'm doing mitral TIA. I mean, jets that come straight back, okay, but when I see an eccentric jet like that, either you're distorting the valve or you're missing some of the prolapse.
That's why the venous flow is even more important, because if you want to stop or not, and if you are doing the procedure, assuming that you are doing because the patient was well.
venous flow. 我觉得要送掉重新。
对，再 check 一下。
我们再往 lateral 去一点。
Pulmonary vein flow is not always reversed, right? In these cases.
那刚才那个血流是哪里来的血？
It's not an eccentric jet. They're going posterior, right?
Lateral.
Yeah. 你再 check 一下是不是有 residual prolapse。
这里。
我觉得没往 lateral， 我觉得。
So we have 1 minute left.
Okay.
So in the meanwhile, you make all the check that you need to do in a patient. I would like to congratulate with you and your team for this, nice demonstration of this new device. We don't have in Italy, actually. I don't use.
Yeah, Antonio has the experience.
It's an opportunity for me to learn more about this
absolutely,
device.
You have experience. Actually,
I think you deserve applause from the audience.
Thank
you.
you.
Thank you all. Thank you so much for your.
Thank you very much.
Okay.
And looking forward to have you in Rome next time. Okay, thank you. Let's move on. Skip to the next slide. They've already implanted the valve. What is that? Hello, hi everyone. Can you hear us from Rome? Hello?
Can you hear us?
Yes, we can hear you.
他说听不见咱们。Can you hear us? 是吧？可能连接的问题，听不见。哦，那可以了。
Okay, I'm here. I'm Antonio Colombo, Giuseppe Tarantini on my right. Can you introduce the case and tell what you did?
So I'm Jin Yao here, and we have Dr. Odomi and Dr. here, and Dr. Ximing Liu and Dr. Zhen Mingjiang. So can we share our
Regurgitation.
slide? 幻灯放一下了，谢谢。幻灯，我们的幻灯放以后 ，Yeah. So can you hear our slide now? So this is our case. We did a TAVR for pure AR.
We can hear you.
We cannot hear your voice. You need to increase.
他听不见咱们，就是他听不见我们说话。
Now we can hear you.
Now it's okay. 对。
Yeah.
中心反应。
Okay.
对。
You need to talk.
得把中间那个柱尾拔掉。对，把柱尾拔掉，然后再来一张，对。
We can hear your voice, but we cannot understand what you say.
And so she was evaluated for AVR at that time, including SAVR and TAVR. Because of the high risk and the fragile, the patient.
You need to go close to the microphone. We heard.
就是你的麦克在哪儿？他听不见你的声音，声音好像是有点都发飘吧。Can you hear us？ 他听不见。
We can read the slide.
Yeah, we.
我这可以，就换成这个，换我这个给姚准。
No, we read the slide. We can go to the next one, maybe.
我能听见他，你换我。
你再打一枪吗？就完了吗？打一枪，换一个那什么？
把这个摇准。
Just wait a moment. We'll change the headphone.
Sorry, we changed the microphone.
对。
Okay.
So, can you hear us now? Sorry.
We hear your
voice. The patient
voice.
is severe aortic regurgitation and evaluated for SAVR and TAVR 2 years ago. And the patient is because the high risk for surgery and fragile, the patient cannot undergo the surgery. And 2 years ago, we don't have the
不是那个 M 层。
M 侧是斜着挡线后往前。
你再回到那个平面。
我回到上个条。可是我从这水流感觉有后往前方向点。
对，有后往前的，这挺怪的。
还有就是有没有损伤？
也有可能，因为刚刚在这边夹。
你这里，这边你那个还是multi-view先打清楚。
而且你再夹它，
这不能动，
它面积已经不大了。
我觉得不能再动。
不动。
再动，我觉得这个2次加紧。
怕，不然你看后往前你没法解释。
这么多的血流从哪里来的？
这主干的，主干的前下血。
我觉得那个你这个orientation太迟了一种，它一拉就这样啊。那个 edge to edge 就对不好。
确实有一束的。
是吧？这有一束后往前的。
对。
我就担心这个
对，当时夹
后叶
会有损伤。
夹有损伤。那你先把这个旁边梁先看一下，你先 L 侧看一下。
L
下怎么这么难打？而且两边都有，是吧
？L 侧比肯定比前面那次要好。
少多了，对，前面那次是一大轨绕出来。
因为这个 L 侧这边口子也很小，也没太多空间。
你这个主动脉瓣为什么前下血流这么那个？
啊？
主动脉前下血流很快。
对，为什么这么快？
颜色比较黄。
你能不能把它打清楚？到底这个夹子旁边怎么样？
这 L 侧确实有一点。
L 侧是到底是什么呢？柴鱼头吗？还是至少你现在后叶是好的，
是的，
对吧？没有说撕掉，我现在不建议打开了。
至少首先的夹子
不行了，我们再抗水再加一点。
加不了。
他们是救治的。
而且这个血流的方向啊，兄弟，感觉也不是前往后打的。
那如果是这样的话，就说明贴起来是有问题，你不觉得吗？也就是我们逆回来是有点问题。
现在是后往前，半夜会不会双打双加？
那如果可以的话，我们就先松掉了。
可以。如果我再调整也就算了。
我就不要
这个推选不能太直的，因为你在脚上拉，你一定要把它送过来。是。
那现在我觉得挺好的，我就也不要再夹了。
这送过来以后，你的夹子长，夹子就缺点就。
那我们先放着再说。
那我们就做比较。
新伟，你觉得呢？
我就可以，反正这夹子稳定的，L 这反正也不多。
对，我们放完以后再好好评估一次再决定。
好。
因为我觉得你现在再放掉以后，可能损伤就更大了，到时候就。
一圈，两圈，然后2圈就好了。稍微宽一点。那准备放了。
总体还行吧，我觉得。这个回放，
做完了回放。
啊，你看还有做完了回放，
这样好像也可以。
你这拿 case 不一样。
我感觉变成录播 case 了。稍微接一下，小小。点可以主动了。在那个。
要不然领导先下来，转播结束了。
什么？
好像感冒了，要不要先下来？
这还没结束呢。
还要。
对，我们放完再评估一下，不着急。
哦。做领导要。
这个地方你怎么搞得这么体贴哦？
不是，我原本是要搞点药吃。
准备啊，新伟。好。好。
夹子是稳的。其实也不多啊，这上面。
那是
把针出来了。
那我们针出来。
你看看那个。
把中看往前。
大家怎么样？还可以的。那个。
这血流已经挺花了。
又担心这个。
担心。
有人想加入哪吗？
其实这个我觉得往本身选短的应该。
已经到4道，选短的可能不好。
对。
我来想啊。
是的，我觉得因为它这个 AP 实际上应该很大。
前面一个是有个毛的颜色。
3、4的样子。
是你后面吃过了，你如果斜一点，这个。 还是够的。
好
3个吧。
要不要再补一个？
就是在来的时候有个
你先看一下。
管宅的。
lateral ones 可能背地也是有机会了，他可能进不去了，就是迷恋那个地方。
迷恋还好，迷恋没怎么弄。小雪，你再看看那个。
这个大手帅点。
大家来看了。现在可以吗？好 ，OK。哦，土架受影响。好。大鞘这个土架受影响，它这个形状有转位，是吧？
是的。
所以它不好打。
对，所以世界纪录那就看不清怎么样。
多是不多？
多是不多的，但是确实有一股斜的，你看。
确实有由后往前的斜。
它不应该有由后往前。
这个你把它看清楚，这不行吗？这边呢？
这里说。我觉得可能可以这样。
啊，你看一下这里。
这个代价挺大的。
这是我的夹子了嘛，然后就是我夹子边上一点点，这里是偏的，但是呢，量倒是没有很多。
等会这里，这里能切清楚吗？啊，残余托肯定不对。
不是残余托。
对吧？因为残余托往是肯定在前
它本身是后前叶。
它是前叶托起的。
对。
所以这个由后往前可能只能解释就是损伤。
损伤。
只能损伤。
你手上拉过去，你这样拉，把半夜拉，把这个拉。
那这边你做一个好一点，
拉这个角度出来。我倒不认为损伤没那么好，我觉得是一个对回缘不强。啊。你跟他那个对缘。
就如果这样就是
你再加orientation。
orientation 的问题。
而且你因为你本来就长，你如果这样斜一点，把两个消耗掉其实。你这样我当时为什么选长？我觉得应该这样的，你这样搭上去就完了。
你这样看方向还可以。
但我觉得
方向线看了看看。
把这个拉上去10几千。
我觉得挺好。
那个水流是什么的？
放过去。
那个是主办的。
有部分是这样的，看一下啊，你看，有一部分是这样，
就这个
是这个来的。
这个不是的，这个不是的。
这是 L 色来的。
不，你现在这一大片不是的。
不，这一束是 L 色来的，这边转过来的，实际上它口这边就这里一点点的。我把你不用，把这个切出来给你看。
有这么多的反应啊？
因为它是斜过来之后会导致它转出来的出来就很低，然后你从这边稍微来看，你拿好。
反正是从这边的后半出来。
我觉得这1到2吧。
我觉得1到2。
1到2。
我觉得那个后半其实我们那个地方咱还没去碰，就是靠近。不，你那片血的是哪来的？
上面那片
最大的那片。
这里啊，这个啊。
你这右下方那个。
右下方。
你鼠标指一下。
这边啊。
这片大概。
这边是我这边现在长，它就是转出来的。
转出来的不少啊，这个。
是挺细的，它转出来。
它现在转到上面弥散了以后。
对。
实际上它不多，是这个意思吗？
口子实际上就是这么一长。
你还有那个主动脉血。
主动脉还有倾向
对，它主动脉还会混在里面。
对，所以从你单位这里来看，它这里有一部分是主动脉的血流刮过去的。
是的。
临床效果，你怎么能鉴别这两个血？
你要进胸再看一眼。这里其实不多的，这里多的，不多了。那我问你啊，你这个是什么原因？
我觉得可能王老师的。
王老师是说的是 gap 的问题，而不是，对吧？是 gap 的问题，而不是它真正的脱水 prolapse。
我觉得它不算是 prolapse。因为我看我们切了夹子边上我们可以明确可以看到，没有明显的看到一个脱水。
症状会不会改善？
还有这个左室流速道可能流速很快，
会不会梗走了？
对。
这要液体补一点，我感觉这心腔很空。
心腔比较小，
这
里有一点高血动血状的表现。
还有这个病人美托洛的也有一点。
是。
这多大年龄
？71岁。
71岁。
有正妈房颤。
但这个心腔很小。
是的，我觉得可以考虑。
液体补一点。
液体补一点，
没有狭窄。
那就结束了吧？
我觉得结束了。
结束了，好，OK， 挺好，不错，今天4点半就放个座。
病人可能吃点药。
你明天还来吗？
不一定的，看情况吧。明天你昨天有吗？
没有，明天还有7个。
我看。是什么？是主要什么问题？
明天2点半。你要不跟现在王是在，你跟俊杰打个电话看看明天有什么会议啊？
哦。